Good afternoon, respected chairpersons and distinguished faculty members and the delegates. It's an absolute honor and privilege to be a speaker in this prestigious BDCon, and I sincerely express my thanks to the organizer for providing me the opportunity to speak on such an important topic of heart failure with preserved ejection fraction, which is also known as HFpEF. We know that heart failure in a simpler term is known as a condition where heart cannot supply adequate oxygen to the metabolizing tissues despite having adequate filling pressure. And these definitions of heart failure are applicable irrespective of the LV systolic functions of the patients, and LV systolic functions are traditionally estimated by measurement of LV ejection fractions by echocardiogram. When heart failure with reduced ejection fraction, where their LV systolic function is less than equal to 40%, so in this arena of reduced ejection fractions are evolved a lot. There are proper diagnostic algorithms there are better therapeutic options, both drugs and devices. Drugs like 4 pillars, we say that's beta blockers, MRA, RNE and SGLT2 inhibitor, and if you incorporate vericiguat, we can tell this 5th pillar of heart failure reduced ejection fractions, and the devices like CRT, they have minimized both mortality and morbidity. Whereas the HFpEF or preserved ejection fractions variety is still remains elusive, pathophysiology is very ill understood and very limited therapeutic options. But unfortunately, the incidence and prevalence of the HFpEF are rising because of our sedentary lifestyles and obesity and increased lifespan. So which is why it's so important to discuss in a forum like that. So in next few minutes, I shall be talking about the defining criteria of the HFpEF and the important pathophysiology. Importantly, the management incorporates the landmark trial and the accredited guidelines. And before concluding, I would present a small case scenario. So there are plethora of evidences, but I mostly took reference from the latest ACC guideline, this American College of Cardiology guidelines. So heart failure ejection fractions, the magnitude is almost half of the all heart failure cases globally. And if we see the table carefully, they will better depict the exact epidemiological scenario currently. So the incidence as well as the prevalence of HFpEF are rising of late. And if you see the rise of HFpEF in compared to the reduced ejection fraction, rises more in HFpEF, both in incidence and prevalences. If we see the gender discrepancy, though the female prevalence is more than male, but the incidence is almost similar across the gender. And the outcome, mostly the mortality outcome, almost equivalent in both variety of the heart failure, though the cardiovascular mortality is still on the higher side in the heart failure with reduced ejection fraction. So the ACC they coined the term the universal definition of heart failure, where they define that the symptoms as well as the signs of heart failure caused by either a structural or functional abnormality of the heart, along with either of the following, either the elevated natriuretic peptide systems like the BNP and NT-proBNP, as well as the objective evidence of the cardiogenic pulmonary congestion or the systemic congestions. So there is a small caveat regarding the NT-proBNP or BNP in the context of HFpEF. Here there is a relatively lower levels of natriuretic peptides compared to the reduced ejection fraction variants compared to the similar level of LVEDP, as well as the obese individuals, they tend to have the lower levels of BNP compared to the normal individuals. So these factors make the diagnosis of HFpEF even more difficult. So this is a historical framing of criteria which we are taught during our undergraduate days for diagnosis of clinical diagnosis of congestive heart failure, which comprised of some major and minor criteria, and namely this orthopnea, PND, pulmonary rales, jugular venous distensions, cardiomegaly, S3, etc. And 2 major criteria or 1 major criterion and plus 2 major minor criteria suffice clinical diagnosis of congestive heart failure. And then you have a phenotypic classifications, and classifications have almost uniform consensus with American College of Cardiology and European Society of Cardiology. They define reduced ejection fraction where the LV function is less than equal to 40%, where the LV function more of 50% or more, it's coined as HFpEF or preserved ejection fractions. In between there is an entity which is known as mildly reduced ejection fractions, where the LV function comprises from 41 to 49%. This is another entity which is known as heart failure with improved ejection fractions, which is incorporated as a separate phenotype by the SEC, though ESC, the European guidelines, didn't accredit that. This is known as improved ejection fraction, where the patients previously had systolic function less than 40, and with response to management, if there have been improvement of the LV functional parameters, they are clubbed in the term LV improved ejection fractions. So when we have a clinical scenario of congestive heart failure, and if there is an echo showing that LV function less than 40, so our job is much easier to diagnose heart failure. Whereas if we found an LV functions more than 50 with a clinical features of edema, dyspnea, job is even tougher because there are a lot of mimicking conditions, both the cardiovascular mimics and non-cardiac mimics. They can exactly reflect the same scenario. So non-cardiac mimics like nephrotic syndrome, cirrhosis of liver, interstitial lung disease, etc. Still non-cardiac mimics can be distinguished, but there are certain cardiac mimics like primary pulmonary hypertension, constrictive pericarditis, valvular heart disease, they need to be ruled out, but the amyloidosis, sarcoidosis, hypertrophic cardiomyopathy are at times very difficult to distinguish even after detailed echocardiogram, and determining this diagnosis is very important because they have separate sets of natural history, prognostications and therapeutic approach. So to make a job easy, there are certain scoring systems are devised which will help us to understand and diagnose the HFpEF. So this HFpEF score, this is more simplistic scoring index that comprised of some clinical variable and some basic echocardiographical parameters. So the H stands for the heavy hypertensions, then you have atrial fibrillation, pulmonary hypertensions, elderly individuals, and filling pressures assessed by the echocardiogram. And the cumulative point is 0 to 9. More the score and more the probability of the HFpEF. And there is another scoring system is there, the HFpEF score, which is far more complicated but more precise and specific. It incorporates advanced echocardiogram like tissue Doppler echocardiography and strain echocardiography parameters, as well as the biomarkers like NT-proBNP, and you can see the cutoff of biomarkers varies whether the patient is in sinus rhythm or and the patient is in the atrial fibrillation. And if the score is more than 5, there is a very high probability that we are dealing with a case of heart failure with preserved ejection fractions. When there is an intermediate score of 2 to 4, then you need to further investigate whether you can go for a stress test like dobutamine stress or exercise stress echocardiography and assess the E by E prime ratio after stress. And in some cases, we have to resort to go for cath lab for invasive hemodynamic measurement for LVDP or pulmonary capillary wedge pressure. So this is, in a nutshell, the diagnostic algorithm of HFpEF. When patient presents with us with dyspnea and edema, you rule out the non-cardiac causes like nephrotic syndrome and cirrhosis. Then you apply the universal definition of HFpEF criteria, heart failure criteria, rule out the mimics, and you try to apply those scores I mentioned in the earlier slides, and you can designate a case of HFpEF now. So there are a lot of comorbidities. The hypertension still remain the commonest comorbid conditions apart from atrial fibrillations, obesity, CKD, sleep apnea, and obviously the aging of the populations. So there are a lot of pathophysiological hypotheses, though still the mechanism is very ill understood. The very recent hypothesis, they are saying this, all these comorbid conditions, they set in some systemic pro-inflammatory conditions that results finally in the endothelial dysfunctions and microvascular inflammation, results in liberation of cytokines causing myocardial damages, fibrosis, stiffening of the interstitial tissues, as well as the impaired NO production. Ultimately, it will result in myocardial dysfunctions. Apart from that, there are this compounded by hypervolemia caused probably by the RAS activations and also the restraint of pericardium by accumulation of pericardial fat and also the more afterload because of the hypertension and aortic stiffening. All these mechanisms put together ultimately will result in elevations of the LVEDP. LVEDP is represented by the red curve and the pulmonary capillary wedge pressure, which is represented by the blue line. So all mechanisms put together will cause elevations of these two parameters, ultimately lead rise to the congestive symptoms of heart failure. This pictorial depiction is a very good description of the phenotypical spectrum of HFpEF. You see that to begin with, disease had started involving the left ventricle only when there is a diminished LV compliance and relaxations. So it results in elevation of pulmonary vascular pressure only during exercise. So patient will have symptoms only during exertion. Then the disease further progress. It involves the left atrium, causing left atrial remodeling and compliance and mitral regurgitation. So persons will have enhanced pulmonary vascular resistance. Even during rest, they will have resting symptoms of dyspnea, orthopnea, and intermittent atrial fibrillation. And if this is further progress, this will incorporate the right heart, both the right atrium and right ventricle, giving rise to more RV dysfunctions, pulmonary hypertensions, and systemic overload and pulmonary atrial fibrillation. So this will help us to understand how the disease progress in an HFpEF scenario. So during walk-off, this is a routine examinations and biomarkers, but most importantly, we have to go for the echo, detailed echo with Doppler, tissue Doppler, and even the strain imaging. And in selected cases, we need to do a cardiac MRI to distinguish the mimicking conditions. And invasive hemodynamic monitoring remains the gold standard, with very hardly performed off late. So I am not going in detail of these slides, but shown some complex echo parameters to assess diastolic functions, but only thing just I need to focus that three parameters we mostly look in the Doppler echogram. One is E by A ratio by transmitral flow velocity, and E by E prime. E prime stands for the septal and lateral mitral annular velocity, and with ratio of the mitral E velocity and the tricuspid regurgitation velocity, which is almost a surrogate marker to determine pulmonary artery pressure by echocardiogram. And there is another grade, is grade 4. I haven't incorporated in the slide. The grade 3 and grade 4, the parameters look similar, but only the difference is in grade 3, the parameters can reverse after doing procedures like Valsalva. By reducing the preload, the things can be reversed, where the grade 4 is a stage of irreversibility. If we have to perform an hemodynamic study by catheterization, we do simultaneous the left heart and right heart catheterizations, and we assess the pulmonary capillary wedge pressures and LVEDP. Both in rest and in indeterminate cases, we have to advise certain supine exercise that can further will delineate the LVEDP and pulmonary capillary wedge pressures. The treatment approach is, management approach is multi-pronged, starting from the non-pharmacological measures like obesity reductions, cessation from smoking, etc. Treating the comorbid condition is of paramount importance. You need to treat your hypertension, diabetes, CKD, sleep apnea, and there are very limited scope for pharmacological, and certain device-based program is there. So until very recently, diuretics is the only drug which were recommended, incorporated in the guidelines. It is only used to relieve the congestive symptoms and use the lowest possible dose and stop once euvolemia achieved to avoid diuretic-related complications. Then come the RAS inhibitors, the CHARM trials, PRESERVE trials, and all. They didn't show any remarkable changes with ARBs. Only in CHARM trial there was modest reduction of heart failure hospitalizations. It's still used only to treat the coexisting conditions such as heart failure. ARNI, which has been considered is a magic drug while treating the heart failure in reduced ejection fractions, whereas in the heart failure preserved ejection fractions, the data are not so promising. In Paragon heart failure trial, they show there is no reduction in the incidence of the primary outcome of severe death and heart failure hospitalizations. But if we look into the data more carefully at the subtype analysis, there are certain benefits found in the women and in patients who are LV functions is in the bit lower side, where the LV function is less than 57%. And the Paraglide heart failure trial, there were a reduction of NT-proBNP from the baseline after in 8 weeks, but there was no improvement of the quality of life. So regarding these findings, the US FDA recently approved ARNI in selected cases of heart failure preserved ejection fraction, where specifically when the LV function is in less than 60%. Once again, beta blocker, the trial is not encouraged. It's just used for the coexisting conditions like atrial fibrillations, post-MI and angina. And MRAs like spironolactone, who have shown to have potential benefits in reduced ejection fractions, but the MRA trial, the TOPAC trial, conducted in HFpEF with spironolactone, there was not a significant benefit in the primary outcomes, but in very subtype analysis, they found that there was reduction in individual component of heart failure hospitalizations, particularly when the LV function was in the less, and there were huge regional variation of the TOPAC trial. People in Northern America, they responded well with spironolactone, whereas people in Russia and Georgia, they didn't fare well in this trial. In the recent concluded trial of Finarist HF trial, it's done with finrenone, it's a new generation's MRA. They found some encouraging result, but more and more trial needed with the molecule of finarine. So that's why finrenone is not incorporated if any of the guidelines yet. Then come the SGLT2 inhibitors. It is traditionally, we know that it is an anti-diabetic medications, but they have potential cardiovascular benefits, as it demonstrated at effects in the heart failure in reduced ejection fractions by the earlier trials. So that has encouraged to study empagliflozin and dapagliflozin in HFpEF also. The Emperor Preserved and Delivered trial that shown that there is a reduction in the primary outcome, the severe death and heart failure hospitalization. But if we go through the trial more carefully, these outcomes were mostly driven by the reduced heart failure hospitalizations part. There was no statistically significant outcome in diminishing the cardiovascular mortality. Another thing we found with particularly the empagliflozin, there was more improvement of the health status and more additive benefits of the MRA, particularly patients with who are receiving MRA spironolactone. The commonest cause of discontinuation of MRA is hyperkalemia, but if we concomitantly used with empagliflozin, so there are lesser incidences of discontinuation of MRA because it causes lesser chances of hyperkalemia. So depending on those trials, European Society of Cardiology has given a class 1 indication in our SGLT2 inhibitor in the management of HFpEF, where the ACC, they're giving a class 2A indication of SGLT2 inhibitor in the HFpEF. Vericiguat, which is a soluble guanylyl cyclase inhibitor, it has shown excellent result in heart failure reduced ejection fraction, as shown by the Victoria trial, whereas the in HFpEF, this is a trial called Socrates Preserved trial. The trial didn't show any benefit in the management of HFpEF. We know that HFpEF is associated with a lot of metabological derangement, obesity. So semaglutide, which is still an endocrinologist domain, so the trial showed some improvement of quality of life and improvement of exercise tolerance, though it's not been incorporated in the guidelines because more studies are needed. So I'm going to talk about the device, which is in HFpEF, one of the commonest problems we encounter is the fluid liability state. Sometimes patients become bloated, sometimes very dry. So this is a CardioMEMS is a device which is a small, tiny, invasive device implanted by transcatheter in the pulmonary artery, which will measure the pulmonary artery and which will transmit the data to the treating cardiologist. So this transmitted pulmonary artery pressure will exactly tell us about the fluid status of the body. If in the impending heart failure cases, there will be elevation of pulmonary artery pressures, and depending on that, we can do titrative fluid balance, and as well as we can augment the diuretic doses. So Champion trial was conducted with this device, and which shown a remarkable result with significant reduction of the heart failure hospitalization. So ACC has recommended 2 minutes please. Class 2B indications, particularly is indicated when there is recurrent hospitalizations despite GDMT and who have a cardiorenal syndrome. So this is a pictorial demonstration with a radiological picture of this device. So in a nutshell, this is summarize the guideline recommendations when the diuretics has been given class 1 recommendation, but it's only to relieve the congestive symptoms, where the ARBs and the MRA has given class 2B recommendations by the ACC, but the ESC didn't give any recommendation, just been asked to treat the coexisting conditions. Rest of the drugs still not been incorporated by any accredited guidelines, and the CardioMEM device has been given class 2B recommendations. This algorithm, this chart, which must understand for the treatment of HFpEF. Once we have established the diagnosis of HFpEF, if there is no other contraindication, you begin SGLT2 inhibitor as soon as possible. And if the patient is fluid overloaded, you give and titrate the diuretics. And despite diuretics and SGLT2 inhibitor, if the patient's having still congestive symptoms and frequent hospitalization, you start MRA. And for MRA, you have there is a gender specific guideline difference. For women, we have to use in all kind of EFs, where the male we have to use where the LV function in less than 50%, 55%. And if the patient is still having recurrent hospitalization, we can use ARNI for women all spectrum, and for men where the LV function is less than 55. And in ARNI eligible cases, we can use ARB. So why there is the gender specific protocol difference? So there's a hypothesis is that the both ARNI and MRA, they act better when there is low LV function. And for women, the remodeling is more concentric, where men remodeling is more eccentric. So when we have a concentric remodeling, there is a small LV volume. And when we estimate LV function by echo, it's end diastolic volume by end systolic volume by end diastolic volume. So naturally, we underestimate LV function when a concentric remodeling. So women of LV function 70% in a heart failure preserved ejection fraction can have an actual LV function of LV function less than 50. That's why women across the EF, the ARNI and MRA recommended, but for male, when their LV function is less than 55%, then only it's recommended. These are starting and target dose we must have. Now I will be just briefly talk about a case scenario. As interesting case, a 57-year-old lady without known hypertension and diabetes presented with stage NIOHF 3-4 dyspnea, palpitation and anosarca. She was hypotensive with irregular pulse, atrial fibrillation with low ventricular rate, normal KFT, slightly low hemoglobin. So when we did an echo, we found there is a concentric LV. This is the LV septum posterior wall. This is concentric, and we measured the LA. Left atrium was enlarged, is 46.5, and the if we function assess the LV function by TCOS, this is LV function was 62%, and that both the septum and posterior wall was quite thick, 16 and 19 respectively. And this is a four chamber view. We can see the right atrium is also dilated and mild pericardial effusion we can see. And this is IVC. So classical heart failure scenario, dilated IVC, and this is pleural effusion, this is collapsed lung. So patients having normal LV function, dilated LA, concentric LV, biatrial enlargement with heart failure scenario. And this is a Doppler tracing. We can see the E by E A ratio is 4.47. And the measured the E prime, so E by E prime was around 16-17. So patient having concentric LVH without hypertension, without aortic stenosis. So we needed the further investigation. As was mentioned in some of the cases, we need to re-investigate. So I sent the patient for cardiac MRI. This is a cardiac MRI showed patients having a cardiac amyloidosis. And for the hematological investigations, I sent the patient to the hematologist. They found the patient suffering from multiple myeloma. So that's how we can reach at a diagnosis. So it's a very complex situation. So my take-home message that it's a very complex heterogeneous disease. The concepts are evolving, only therapeutic options being the diuretics, SGLT2 inhibitors, certain cases RNA and MRA, and management of comorbidities. Ruling out mimics are extremely important, and most importantly, it's not only the domain of the cardiologist, it's a multidisciplinary approach needed comprising of endocrinologists, nephrologists, and the pulmonologists. Thank you for patience hearing.